Hi, folks. Welcome to the webinar. We're going to get started today. Today, we're here to talk about reducing denials and the threat of external audits. So today, we're going to talk about a formula where we really feel like you'll be able to drastically mitigate denials and those external audits that are showing up at your back door. So that's our topic today. Really excited to talk to you about it. Just to start off, my name's Dana Finnegan. I'm the Director of Market Strategy at MD Audit. For today's webinar, we just want to start you off with a few housekeeping items. The first one being we are going to send you the deck we're using today. We're also going to send you the recording. And we're also, for any of our webinars, the intention is to send you home with some nuggets of information that'll help you really bolster your revenue integrity and billing compliance programs. So before we jump in, let's talk a little bit about MD Audit. They are sponsoring today's webinar. Again, we're not here to push our product on you. We're just here to tell you what we're seeing in our community. So a little bit about that community. We serve 70 of the top 100 health systems with $1 billion plus in NPR. There's over 30 years of experience in the billing compliance and revenue integrity space. We serve over 2,200 facilities, almost 700,000 providers, over 75,000 coders, et cetera. So what we're really here to say through those numbers is the fact that we have a lot of experience in this space, understanding the pain points, how to solve them, and also sit atop a ton of data that help us point out trends to you that we're seeing that will help you in your daily work lives. So the first thing we want to really look at today, and I won't read this quote, you can kind of eye it as I'm talking to it, is payers, both government payers, commercial payers. This one is a very specific quote for your government side of the house, but really they're utilizing AI and machine learning to highly scrutinize your claims. Predictive modeling, artificial intelligence, you name it. That is a big part of their budget now in, as you can see, 2023 and beyond. Excuse me. And really what that's meant to do is the scrutiny of your claims has never been historically so high as it is right now. So that's automatically going to output into an increase in denials, as well as the receipt of those external audits from RACs, MACs, TPE, whatever it may be. So, at the end of the day, we're here to talk to you about that there is technology out there that you can trust and partner with that can keep you in the driver's seat and your head above water when you're going to be receiving such intense scrutiny. We have a tendency to talk a lot about our government our government payers, but let's take a little bit of a concentration now on commercial payers. So one of the things that we've been noticing, this was quoted from an article that we'll send out the source, but what we're seeing in our data as well is that commercial payers are taking significantly longer to pay, and they're denying at a much higher rate than your government payers. Now, we all know that the reimbursement rates are much higher with the commercial payers, but really getting them to pay in a timely manner is a very difficult endeavor. So taking much, much longer to, cut those remits. Now, that circles right back to that they're doing a lot more scrutiny in-house. They're running your charges and claims through predictive modeling and AI and finding every possible reason to deny you. I think the third bullet is the most concerning to me because they are denying claims at a 12 times higher rate than Medicare for RFI, a request for information. So that's things like when you get those CARCs and the supporting RARCs that'll say information needed, documentation needed, attachment needed, not meeting medical necessity. So they're giving you an actual reason, but it's very vague, pretty lame, and it's meant to have you keep scratching your head about what are my next steps to get this adjudicated? How do I appeal this? What do I need to do? So not only at the end of the day are things being more highly scrutinized. But to actually get the remit from the commercial payers, to get them to pay or deny, taking much longer. And then when you actually get it in front of you, you're not really sure what to do with it. It's causing a massive increase in denial work queues and just an overload of your staff in trying to resolve these issues. So one thing I want to really hone in on today, and I think this is some of the nuggets you'll be able to take home that we talked about, was there's, as you know, there's denials for everything. Timely filing, authorization, pre-cert, a million different reasons. But today we're really going to talk about the high impact revenue problem in healthcare, which is when we really look at our MD audit data, again, across 150 clients across the country, we're seeing the healthcare spend in three very specific categories. And that is pharma and drugs is the number one category. The next category, you can see, well, excuse me, for pharma and drugs, 600 billion in spend. The next category, which is durable medical equipment, supplies, and implantable devices, another 150 billion. And then the expenditure and spend for those complex diagnoses, especially for heart, kidney, musculoskeletal, and cancer. So those three categories, there's a massive amount of spend. You're doing a ton of services with your patients. But the problem is in this lower piece, according to our 2022 data, and we'll be updating 2023 very shortly, there's a ton of denials coming from that spend. So you can see in this first sphere, $7 billion in initial denials in the outpatient setting related to that pharma and drug. Over here, 8 billion in initial denials, again in the outpatient setting, related to medical surgical supplies and implantable devices, and in a ton as well for those complex diagnoses. So at the end of the day, we're going to talk about how MD Audit can really help you hone in on these three categories and really, really reduce the amount of denials that you're receiving for them. Okay, the next part of this is just, I thought it would be kind of funny to take a look at this. It's a little dizzying. So along with all of that scrutiny of your claims and denials, is this alphabet soup of external scrutiny. So you're receiving letters from RACS, MACS, UPIC, SMRC, TPE, you name it. We're really even seeing in the MD audit community where, you know, MACS will approve something and the RAC will come back and do an external audit. So again, just to level set, today is to help you understand how technology can help you reduce denials, significantly reduce denials, and at the same time, the threat of external scrutiny. Because if you're really submitting the way payers want you to and expect you to according to their policies, you will reduce denials and the threat of external scrutiny. Now, this is just kind of I want you to focus a little bit on this screen. We're going to go into the platform and show you this in action. But what we're really here to say is, if you can get to the holy grail of predicting payer behavior proactively before that bill goes out the door, you're going to be able to essentially reduce denials and the threat of external audits. We have technology, predictive technology in MD Audit that can look at your pre-bill charges and tell you and bump it up against the same payers you're submitting to on a pre-bill basis to tell you, you know what, before you send this out, they're going to deny it for this reason, and even give you recommendations on how to fix it. So you're improving first pass pay rates, reducing days in accounts receivable, and really help bolster your bottom line. So this is just a screenshot from the platform, but we're going to get into it in a moment. What you're really seeing here is a predictive capabilities where we can tell you exactly what you need to do on a pre-bill basis so you get those claims paid the first time around. Now, before we jump into the platform, I want to talk a little bit about revenue integrity. If we talk to 10 different clients in our community and ask about, you know, what's your definition of revenue integrity, it can change quite a bit across clients. That said, what we've realized is there's a lot of silos existing within revenue integrity. So revenue integrity can be siloed from coding. Coding can be siloed from revenue cycle. Everybody is kind of, everybody wants to work together, but there's a lot of barriers to that. What we're showing here is that the data that is at the heart of everybody's needs is your billing data, your 837Is, your 837Ps, in the payments data, the remit data. That data, if shared cross-departmentally, can help you form a team, an impenetrable team that can go back and fight a lot of the tough stuff that's being sent to you by your payers. So payers want you to stay siloed. They don't want you to use that powerful data to see trends, to go back, work together and say, hey, this is how we can fight that payer policy and reduce denial. So always try to break down those silos and use that data that's so important to help you make the strategic decisions you need to make. Now, the last thing we're going to talk about in terms of revenue integrity is MD Audit's definition of it. So really, there's a lot of different definitions of revenue integrity out there, but we consider it where you're minimizing risk while at the same time as maximizing revenues. So minimizing risk, at the end of the day, meaning make sure your claims are going out with the highest level of accuracy and integrity in terms of a coding quality perspective. Maximizing revenue. Same time, you want them to go out compliantly, but you want to make sure that you're getting the highest level of reimbursement you're entitled to. And I think all of us are doing a pretty darn good job at these top two. Where we're really kind of having an issue is staying operationally efficient. So when we talk to clients, they're working, just a massive amount of denial work queues. And they're spending days and weeks trying to figure out trends on how to make things better. So that's where you can lose your operational efficiency. So again, at the end of the day, we're here to talk about denial prevention and mitigation, while at the same time reducing external audits. Now, this is a case study that we're going to review after we go into the platform to kind of show you one of our most successful endeavors with a client based on them using our technology to help reduce denials and external audits. We'll jump into that in a moment. What I want to do right now is pull up our platform. So we're going to run through an exercise today, a quick exercise to show you how to reduce denials and external audits. So the first thing we want to talk about is whenever you're going to try to get to that place where you're predicting payer behavior, the first thing is to understand historically the systemic hotspots of your denials, where you're being denied, what facilities and why and what payer and so on and so on. Because before you start running pre-bill charges through predictive engines and scrubbers, you want to know where those systemic hotspots are. So right now, I'm going to start off with the first part of our platform called the Revenue Optimizer. This is the part of our platform that ingests 835 remittance advices on a daily basis and really lets you see root cause. And then once we understand root cause, we're going to apply it predictively. And I'm going to show you that in a moment. So let's take a look at this one. Monthly denied amount by functional area over the last 12 months. So we're showing you here a rolling 12 months updated daily. And if you come in and care about, what does my patient access SKU look like? You can see your spikes and lulls. Or maybe patient financial services. What does that look like? Today, we're going to go into coding. So I'm very easily able to see that I've got a terrible month in coding-related denials. So the first thing I'm going to want to do, or one of the things I'm going to want to do, is drill down to root cause. So first thing I'm going to say is, okay, what's the place of service? What does it look like? Coding-related denials. What's the place of service? So I'm able to see that most of it's on the inpatient side. Then I've got a big amount here also on the outpatient side. And we've got some in the office. But okay, now I know I've got a coding issue. I'm going to look at inpatient. Now I'm going to drill down and say, what facility? many of us have many, many different facilities. So I need to get it to that understanding of where is it originating. So it's definitely this facility here. So now I know I have a coding issue on the inpatient side, residing mostly at this facility. Next thing I'm going to want to know is let's do what's the reason? What are the top reasons? Why am I being denied? And I can immediately see here that it's medical necessity related. So in just a few clicks, I know it's coding, I know it's inpatient, and I know that it's a medical necessity issue. It's stemming from medical necessity. Now I'm going to go down and say, what payer? Could be many payers. Is it Medicare? Is it in my commercial side? I can see here it's primarily with this payer. So in just a few clicks, I've gotten to when I say root cause, I mean direction and magnitude. I knew it was a coding issue. It was on the inpatient side. I now know what facility it's happening at. I know what payer. I know it's medical necessity. Final thing I'm going to do, just to kind of show you the power of this, is get down to what DRGs are actually, kind of being involved in that medical necessity issue. And right away, I can see it's this one right here, followed by this one. And finally, I'm just going to say what account numbers. We want to get real granular. How many account numbers? And it's just one for that DRG. So again, just a few clicks, I get to the information I need to understand more about systemic hotspots of where this is happening. I'm going to do another example here. That was a functional areas. Let's go into payers. So here's another dashboard, payer mix of denied claims over the last 12 months. And I can see, again, a rolling 12 months updated daily. But what I like about this is the intuitiveness and navigation is I can start with this payer here in the most current month and kind of scroll and see historically very little denial, but in this month, just getting crushed. So I'm going to drill down here in this payer. And again, I'm going to say, what's the reason? That's your claim adjustment reason code, your CARC. And it's basically telling me what we talked about, all of those lame, vague reasons. Claim service lacks information. That tells me nothing. So now I'm going to drill down and get to the corresponding remark. It's going to give me a little bit more information about why that payer is crushing me so much with denials. And it's thinking, and it's telling me here, let's look at this one. Missing, incomplete, deactivated NDC, giving me some really good information. Again, I'm going to drill down to payer. What payer is telling me that? Is it one? Is it many? And it's one payer. So again, another example of manipulating data very easily to understand systemically what facilities, what payers, what DRGs, what CPTs are contributing to my denial difficulties. Now, that is, drill down technology. But what we want to show you that we also do, which is really interesting, is some AI. So a lot of folks will say, oh, my slicer dicer can do that. Let me show you something that we throw on top of that that's significant in helping you understand systemic hotspots of denials. So we're going to go right here and see some banners that we have, diagnosis-related denials. What's nice about it is I can see my spikes and lulls, but if I ever wanted to kind of just see, why did we have this spike? It went from 66,000 to doubled 120,000. Well, I'm just going to click those 2 points and I'm going to run an analysis. This is AI in action, telling me why those diagnosis denials went up, doing the work for me. And it's come back and said, you've got 712 account numbers that were involved in that spike. But this account number and this one, these are the ones you want to go in and take a look at. Let's see, payer. You've got a huge amount in your payer mix that you're submitting to, but these two payers, they're the ones that are scrutinizing you and denying you. Let's look at reason. Okay, a lot of reasons, but the number one reason causing that spike is these diagnoses are not covered. Let's see what facility that's happening at. Of my 15 facilities, it's this facility. I'm going to go back into adjustment reason name and say diagnoses are not covered. And I'm going to drill down and say, what were those diagnoses that are not being covered? And it's going to come back to me and it's going to tell me it's really this one. So again, that is on top of all the dashboards that we can provide to help you understand root cause and direction and magnitude and systemic hotspots. There's excellent AI as well. I'm going to show you one other thing before we jump in and show you how we can be predictive, but we're going to go into conversational AI. And what does that mean? There's a lot out there about conversational AI, generative AI. Well, I want to ask this a simple question in plain English. And I'm just going to go down to this one here. What facilities had the highest amount of denials last year? So I'm asking it in a plain English question, and it's actually spitting back, here's your number one facility that had the highest amount of denials last year. Now, I may ask that in a different way as well. And I'm going to say, what facilities had the highest amount of denials last year? And it's generating my answer. It's using AI to do that. It's taken a little longer, and it's come out with this. I've got a whole list of my facilities and why their denials are happening. What are the reasons? So I'm just asking this in plain English, and it's sending me back an answer. I don't need to understand how to write a query. You can see show query right here. I don't have a technical background. I don't write Tableau. I don't write SQL. This is a way our system allows you. You can see here, I even made a spelling mistake, and it's still giving me the data that I need. So just want you to see that on top of all of the capabilities that we offer, and I'm going to do one more here. And we're going to ask one that I asked before. It actually tracks what I've asked before. What DRGs had the highest amount of denials last year? I may want to know that. And again, I'm just asking in plain English. I don't have the time to go into an epic report writer or anyone else. I just want it to give me my answer. And it's lining up for me. Here are your DRGs with the highest amount of denials. And many of us familiar with sepsis. And then I can drill down and say, where do I start? What facility? So now I know my DRG, sepsis, and it's happening most at this facility and the ability to drill down. So really what we did so far, folks, in this first part of the exercise is help you, show you that we have technology that can get you to root cause. Why, where are you seeing these denials most? Why, what payers, what facilities? Now, what do we do with this historical data? Well, what we do is then come in and configure our MD Audit predictive engine. And let me just set this up for you and kind of tell you why we're going to ask you to configure it. There are many vendors out there that'll just say, give me 100% of your pre-bill charges, and I'm going to run them through my predictive engine. That is bad advice. We want you to configure our predictive engine, but do it in a smart, practical way. So now what you're going to do is take those findings you had from your historical data and come in and say, I know that of my 15 facilities, these are the 3 that are having the biggest denial issue facility. I also know that these payers, I've got a lot in my payer mix, but these are the payers that are denying me most. And then I also know that there's certain DRGs, like those pharma DRGs, that are really bleeding with denials. And there's certain DRGs as well. And even on the outpatient side, I'm seeing certain CPTs. So you're able to go in again and configure it so our predictive engine will specifically interrogate these areas that you've just configured and say, now looking at those, this is what's going to deny, why it's going to deny, and even show you how to fix it. Again, we take a very targeted approach. We don't want you to hold everything up because it will then hold revenue up. So don't listen to any vendors that are telling you to hold everything up. So that's why we have you configure it. Now let's go in and show you the power of our predictive engine. And as we're pulling this up, I think this is the secret sauce. There are many vendors out there saying we can mitigate denials. We can do this, we can do that. Let me tell you how we're different. And then we're going to go through some of these really cool use cases. So we're different one because we take a historical approach and then apply it predictively. So again, learn from your historical denials to then become more targeted in what you're going to do predictively and proactively. That's number one. Number two, we complement traditional scrubbers, meaning we're not telling you to get rid of your traditional scrubbers. They do some really good things. Claim validation edits, things like that. This layers on top of your scrubbers. We work with many, many systems that have many, many layers of scrubbers, and we know that our predictive engine is catching what those scrubbers cannot. But again, we're not maligning scrubbers. We're acting as another layer on top of it. And the third most important thing is the categories that we're pointing out to you are based on payer policy and adjudication behavior. We have, for the same payers that you're submitting to, we have their adjudication policies and payer behaviors built into our system. And that's what I'm going to prove out right now. And the last thing I'm going to say is this: you're going to get your biggest bang for your buck on what we call our 333, which is those three categories we talked about: pharma drug, then complex diagnoses, and then DME implant supply. That's the first three, those categories. The second three is this gets its biggest bang for its buck on the outpatient side, ASC side, and inpatient side. And then the third three is we are going to really, really help you understand what those RFI denials are for. We're going to tell you what information they're looking for, what documentation they're looking for. And that's how we truly differentiate. Very targeted approach. So let's go into some of these responses that it's going to really prove out why we complement and do find what your traditional scrubbers cannot. So here's inappropriate HCPCS modifier usage. So right away, what I'm going to do is bring in the payer name. Let's kind of show you we can do that. Now, some of this is de-identified because we're not going to share, obviously. We're very protective of our data. But what it's showing is, okay, I've got just a massive amount of account numbers over here. And there you can see what we're flagging, $120,000 a pop. And what it's saying is this payer is saying every time you use this J code or these J codes, and what they're specific to is saying that when you submit those J codes, it's going to deny because a single dose vial or a packaged drugs, they don't contain a JZ or JW modifier. Now I can go in and very easily say, well, wait a minute, did I append the right modifier? And I can see here for all of these J codes, that JZ, JW has not been appended. And this payer is specifically looking for it. I was just at a conference that said people were just being overwhelmed with the JW, JZ modifiers. This is showing that we can run your charges proactively, pre-bill, before they go out the door and say, if you're going to submit to this payer, do a review. Attach that JZ, JW modifier. Now we know it's just not slapping on a modifier. You've got to make sure that it's appropriate and it meets every standard of code and quality. But again, traditional scrubbers wouldn't catch something like this. Let's go on to a different one. I'm going to do treatment diagnosis combination issue. So this is, again, we're seeing those implants that we talked about, part of that big healthcare spend. This payer right here is saying when you use a spinal cord stimulator with spinal stenosis, there's a treatment diagnosis issue. You have to have a very specific diagnosis and able to do this. So I'm going to put in that primary diagnosis. And now this is showing me the diagnosis I've used, but this payer again is saying, if you're going to do this service, with this diagnosis, we're going to bounce it out. It's going to deny at adjudication. This is an opportunity to go back in and say, is this the most appropriate diagnoses? You know, what diagnoses are they going to accept? So it's going to bump it up and allow you to do that research. Let me go to another one here. So let me hover over this treatment coverage issue. So let's scroll down and look at this one. Here's another one that's saying, okay, when you're going to, here's a payer that's saying, when you're going to do cardiac resynchronization therapy with an implantable device, we're going to deny it. Now, we researched this rule, and we even saw their recommendation. What they were saying is if you're going to use an implantable device, you have to have 3 very specific points to say why you're going with that implantable device and not other therapies. Folks, that is not something a traditional scrubber can find. And you can see here, many, many accounts for many, many hundreds of thousands of dollars. I'm going to show you one last one here that our MD audit community struggles with, and we're helping them fix, is biosimilar issue. Then again, many, many accounts, many, many high dollars here, where they're saying, look, you're treating patients. That patient outcome may be good, but biosimilars are available. So this one may not be as easy as putting on a different modifier or attaching documentation, but it's giving you the institutional knowledge to go back and have dialogue to say, we're going to get denied by this payer if we don't use biosimilars. So this was a really quick exercise, folks, but the reason why I went through it is whenever we've tested this in the field and with our MD audit clients, as many layers of scrubbers that they have, they're not catching this stuff. So at the end of the day, what I want you to see is that we have a very specific formula. We can help you use your historical denials to understand systemic hotspots and then apply them to our predictive engine in a very smart way, so you're not holding up all your charges, to then understand on a pre-bill basis what's going to deny, why, and how to fix it to the same payers you're submitting to, and it really increasing first pass pay rates and reducing days in AR. So I want to jump out of our system right now and just pull up one of those case studies. So there's many case studies. We can provide references. We can provide these case studies, but here's one that I specifically work with a client. What it's showing is this is a customer had 37,000 employees, 400 sites, 5 critical access hospitals, 19 acute care hospitals, so on the West Coast. And what they found was they were having a very high denial rate for leadless pacemakers. And when they ran it through they couldn't figure out why, I should say. They were getting a lot of those RFI denials. But when they took those pre-bill charges and ran it through our predictive engine, leadless pacemakers on their outpatient segment, what our predictive engine came back and said was, and I can even go into further detail. This is when I believe Medtronic was the manufacturer. But what our predictive engine was able to say is, you need to attach in a certain lupin segment a clinical trial number. That was part 1. And then part 2 was very specific documentation. And the engine even was able to tell what that documentation should be. So once they started, what they did at that point was they put an edit in their system to hold up all leadless pacemakers so they could put the clinical trial number in that lupin segment, attach the documentation. And with just that, they were able to save between $8 million and $10 million. Well, I should say projected savings between 8 and 10 million. The predictive engine found something that they struggled with for years. Now, the last part of it, in addition to that whole leadless pacemaker, was they also used our predictive engine to see that when they were billing single dose vial packaged drugs for it was actually Medicare and Medicare Advantage, our rule fired for less than a week, and they found about $1 million where they needed to append a JZ or JW. So they were able to go and take those findings back and resubmit those claims, and they've recouped $1 million at that point. So again, and you saw that JZ, JW rule in the platform. So really, folks, what I want you to take away from today is that there are vendors out there. It's a congested space. We're all kind of saying a lot of the same things about hey, we can help you reduce denials, which will then help you reduce external audits. I am very, very confident and stand behind our technology at MD Audit to say, if you work with us, partner with us, we have a special secret sauce and formula that can actually help you do that. So I appreciate you all joining this webinar today. You can see up there, if you want to hear more from us, please go to our website, www.mdaudit.com. And we really hope to hear from you, and we really hope to partner with you. I'm going to end the webinar right now. And again, we will be sending out this deck and the recording shortly. Thanks very much for attending.